Hello students, welcome back to the class of pharmacology. Hope you have enjoyed my previous lectures in which we have talked about the synthesis of cell wall by N-acetylglucosamine, N-acetylmuramic acid, their elongation, and then followed by the cross-linking by pentapeptide chain. We have also talked about the drugs which can block the synthesis of this cell wall. They can either be a beta-lactam ring containing drugs, which are beta-lactam antibiotics, for example penicillins, cephalosporins, aztreonam, and your carbapenems, and the other drugs which do not have this beta-lactam ring. For example, we have cycloserine, vancomycin, phosphomycin, and bacitracin, and other drugs. In the previous lecture, we've also talked about one of the beta-lactam antibiotic group, which is penicillins, and this is the safest drug in the treatment of different bacterial infections in pregnancy. We have classified penicillins on the basis of their spectrum and susceptibility to penicillinase enzyme. We have classified them as narrow spectrum, penicillinase susceptible, very narrow spectrum, penicillinase resistant, and wider spectrum with penicillinase susceptibility. We have also talked about their antibacterial spectrums, and we have talked about 4 drug of choices. Yes, number 1 was the drug of choice for the treatment of syphilis. What was that? You're right, that was benzathine penicillin G. Then we talked about the drug of choice for the treatment of Corynebacterium diphtheria. And the drug of choice for Corynebacterium diphtheria was, yes, come on. Yes, this was erythromycin, which is a protein synthesis inhibitor, and we'll talk about them in the upcoming lectures. We have also talked about the drug of choice for the treatment of infections by Listeria monocytogenes, and the drug was, yes, it was ampicillin. And we have also talked about the drug of choice for the treatment of pseudomembranous colitis, which is, yes, absolutely right, that is metronidazole. In today's lecture, we'll be talking about cephalosporins. Cephalosporins is another group of beta-lactam antibiotics, and they are also cell wall synthesis inhibitors. As we have already discussed previously, that all the cell wall synthesis inhibitors are bactericidal drugs, so cephalosporins, being a cell wall synthesis inhibitor, they're also bactericidal drugs. Cephalosporins, number 1, they are beta-lactam antibiotics. Why do we call them a beta-lactam antibiotic? Because once again, we have a beta-lactam ring. We have a beta-lactam ring in their structure. So because of the presence of this beta-lactam ring, these cephalosporins are termed as beta-lactam antibiotics. Penicillins, cephalosporins, aztreonam, and carbapenems, they all have this beta-lactam ring. This is the reason we name them as beta-lactam antibiotics. Second important thing, that this is a derivative of 7-amino-cephalosporinic acid. So they are acidic in nature. Clear? Third important thing, that they can be designated or classified as first generation, second generation, third generation, and fourth generation cephalosporins. So whenever we classify cephalosporins, which are beta-lactam antibiotic drugs, we classify them as first generation, second generation, third generation, or fourth generation. Clear? So cephalosporins have a beta-lactam ring in their structure, beta-lactam antibiotics. They are derivatives of 7-amino-cephalosporanic acid, acidic in nature, and third, that they are first, second, or third or fourth generation cephalosporins. How do we classify them? We can classify them as first generation, second generation, third generation, and fourth generation. First, second, third, and fourth generation, first, second, and third generation cephalosporins can either be administered through oral route or parenteral route. There are some drugs which can be given through oral route, and there are some drugs which can be given through parenteral route. But fourth generation can only be given through parenteral route. You have to remember this very important thing, that first, second and third generation cephalosporins, some of them are given through oral route, some of them are given through parenteral route, but the fourth generation is given only through your parenteral route. Clear? Now regarding first generation drugs which are given through oral route are cephalexin, cefadroxil and cefridine. We have three first generation cephalosporins which are given through oral route, and there is a first generation cephalosporin which is given through parenteral route, and that is cefazolin. Regarding second generation cephalosporins, the second generation cephalosporins which can be given through oral route are cefaclor, cefuroxime, axitil, loracarbesif and cefprozil. Second generation cephalosporins which can be given through parenteral route are cefuroxime, cefotetan, cefoxitin and cefmetazole. The cephalosporins which belong to the third generation cephalosporins and can be given through oral route are cefixime, cefpodoxime, ceftibuten, cefditoran, cefdinir. And the third generation cephalosporins which can be given through parenteral route are cefotaxime, ceftizoxime, ceftriaxone, ceftazidime, cefoperazone and moxalactam. And the fourth generation which can only be administered through parenteral route are cefepime and cefpirone. So we are talking about another group of beta-lactam antibiotics which are cephalosporins. We've already talked about penicillins. These are cephalosporins which are once again a beta-lactam antibiotic because of the presence of beta-lactam ring in their structure. They are derivatives of 7-aminocephalosporinic acid. They can be classified as first, second, third and fourth generation. And the first, second, third generation cephalosporins can be either administered through oral route or parenteral route, but the fourth generation cephalosporins can only be given through parenteral route. Now, what are the pharmacokinetics of cephalosporins? They can be either administered through oral route or parenteral route depending upon the drug which we are talking about. Second important thing, that they have a renal excretion through active tubular secretion. In case of penicillins, we said that all the penicillins are excreted through your urinary route by glomerular filtration or active tubular secretion, except which was neficillin and ampicillin. Yes, you're right. So in case of cephalosporins, they are excreted through urine through renal tubular secretion. And the same mechanism of probanacid, which is one of the drugs which can be secreted through those acidic transporters, once again secretion of cephalosporins can be decreased by the use of probanacid in the urine. Clear? Third important point, that in case of cephalosporins, cefoperazone and ceftriaxone are the two drugs which are eliminated through biliary route. In case of penicillins, we have ampicillin and neficillin which are excreted through biliary route. In case of cephalosporins, we have cefoperazone and ceftriaxone which are eliminated through biliary route. Clear? Now, next point is that most first and second generation cephalosporins cannot cross blood-brain barrier. And they cannot cross blood-brain barrier even when the meninges are inflamed. In case of penicillins, we said that they cannot cross blood-brain barrier even when the meninges are inflamed. Similarly here, in case of cephalosporins, in case of first and second generation cephalosporins, they cannot cross your blood-brain barrier even when the meninges are inflamed. But in case of your third generation cephalosporins, they can cross your blood-brain barrier. And among them, cefoperazone and cefixime are the drugs. Cephalosporins and cefixime are the drugs which cannot cross blood-brain barrier. Clear? So, first and second generation cephalosporins cannot cross blood-brain barrier even when the meninges are inflamed, whereas third generation cephalosporins can cross blood-brain barrier, fourth generation cephalosporins can cross blood-brain barrier, but among the third generation cephalosporins, cefixime and cephalosporin cannot cross blood-brain barrier. Clear? Then, next, what is the mechanism of action and resistance of these drugs? Number one, they are bactericidal agents, which means they'll destroy the bacteria. Number two, they bind to the same penicillin binding protein present on the cell membrane. If this is the cell membrane of the bacteria and there is a penicillin binding protein, these cephalosporins, similar to other beta-lactam antibiotics, they'll come and bind to this penicillin binding protein. After binding to this penicillin binding protein, they will decrease peptide formation. So transpeptidation reaction will be blocked by the blockade of transpeptidase enzyme. I'll show this in the upcoming slide. And third is the activation of autolytic enzymes. So as you can see here, that this is once again the one complex of glucosamine and muramic acid with pentapeptide chain. They both combine to each other. There is a transpeptidation reaction in the presence of transpeptidase enzyme. When we give a beta-lactam antibiotic to the patient, what happens? This beta-lactam antibiotic binds to this transpeptidase enzyme, and thus there will be no transpeptidation reaction. Clear? So, three important steps in the mechanism of action of beta-lactam antibiotics. Number one, they bind to penicillin binding protein. Number two, they inhibit transpeptidation reaction by binding to transpeptidase enzyme and blocking it. Number three, by the activation of autolytic enzymes. Clear? As we've already discussed in case of penicillins, that resistance mechanism can either be because of decreased permeability of the porin channels, decreased entry of the drug into the bacterial cell. Number two, there can be production of beta-lactamase enzymes which lead to the degradation of beta-lactam ring and thus the ineffectiveness of the beta-lactam antibiotics. And last, that there can be a change in the structure of this penicillin binding protein. Any mutation or change in the structure of this penicillin binding protein can lead to what? Can lead to resistance against that particular drug. Clear? So next is spectrum of cephalosporins. Here you have to remember that the first generation cephalosporins are more effective against gram-positive bacteria as compared to gram-negative bacteria. And as we go further, like from first to second and third and fourth generation, the gram-negative spectrum, antibacterial spectrum against gram-negative bacteria increases. So as you can see here, in the first generation cephalosporins, they are more effective against gram-positive cocci, including streptococci and staphylococci. And they are not active against penicillin-resistant strains. Why? Because beta-lactamase production or change in the structure of penicillin binding protein. Clear? Number two, second generation cephalosporins. Second generation cephalosporins are more active against gram-negative bacilli as compared to gram-positive organisms. For example, E. coli, for example, Klebsiella, Proteus, H. influenza, M. catarrhalis, and bacteroides. Among these bacteria, bacteroides is one of the bacteria which is an anaerobic bacteria, and only cefoxitin, cefmetazole, and cefotetan are effective against bacteroides. Your first generation cephalosporins are effective only against gram-positive bacteria, gram-positive cocci. Whereas your second generation cephalosporins are more effective against gram-negative bacilli, for example, E. coli, Klebsiella, Proteus, H. influenza, M. catarrhalis, and bacteroids. And among them, bacteroids is an anaerobic bacteria, and only cefoxitin, cefmetazole, and cefotetan are effective against bacteroids. Then, third generation. Third generation cephalosporins are effective against gram-positive cocci, which are streptococci and staphylococci. And in addition to them, they're also effective against gram-negative cocci, for example, gonococci, and gram-negative bacilli as well, Enterobacteriaceae, Serratia, and Pseudomonas, as well as against anaerobes, for example, bacteroids, which we have previously discussed. So, third generation cephalosporins are effective against gram-positive cocci, gram-negative cocci, gram-negative bacilli, and anaerobes. Among them, only ceftazidime and cefoperazone are effective against Pseudomonas. As we have already discussed in our previous lecture, that Pseudomonas is one of the very resistant organisms, and among penicillins, piperacillin, ticarcillin, and carbenicillin are the penicillins which are effective against Pseudomonas. Among third generation cephalosporins, we have ceftazidime and cefoperazone which are effective against Pseudomonas. And activity against gram-positive cocci is same as that of first generation agents. And activity against bacteroids is less than cefoxitin. What is cefoxitin? It is one of the second generation cephalosporins which is effective against bacteroids. And effectiveness of third generation cephalosporins against bacteroids is less than that of second generation cefoxitin. So, third generation is effective against gram-positive cocci, gram-negative cocci, gram-negative bacilli, and anaerobes. Among them, your ceftazidime and cefoperazone are effective against Pseudomonas. Your activity of third generation cephalosporins is similar against gram-positive cocci is similar to is similar to first generation cephalosporins, and the bacterioid activity against bacteroids is less than a second generation cephalosporin, which is cefoxitin. Here it's very important to remember regarding gonococci, which cause gonorrhea. Gonorrhea is one of the sexually transmitted disease, and you have to remember the drug of choice for gonorrhea. Drug of choice for gonorrhea. Drug of choice for gonorrhea is either oral cefixime or intramuscular ceftriaxone. Please, students, do remember this drug of choice. Previously, we have talked about a sexually transmitted disease, which is syphilis. And in syphilis, we said the drug of choice for the treatment of syphilis, primary and secondary syphilis, is intramuscular benzathine penicillin G. As an alternative, we can give tetracycline. Yesterday, I said we can give ciprofloxacin, ofloxacin, or spectinomycin, but please correct this, that these drugs are alternative drugs for the treatment of gonorrhea. When we talk about gonorrhea, which is a sexually transmitted disease, for the treatment of gonorrhea, the drug of choice is either oral cefixime or intramuscular ceftriaxone. But if the patient is hypersensitive to beta-lactam antibiotics, then you have to remember that we can go for alternative drugs, which is tetracycline, ciprofloxacin, spectinomycin, or ofloxacin, TCS, which is one of the carrier companies in Pakistan, and ofloxacin. So, then we talk about fourth generation cephalosporins. The spectrum of these drugs is similar to that of third generation, but they show more resistance to beta-lactamase enzymes. So, they show more resistance to degradation by beta-lactamase production. Then, regarding toxicity of cephalosporins. Regarding cephalosporins, number one and very important, yesterday I told you, please, whenever you give an antibiotic to a patient, always give a test dose through intradermal route. If no reaction is seen, then administer drug to the patient. The allergic reaction can vary from skin rash, a simple skin rash, to anaphylactic shock, as similar to your penicillins. Then remember, there is a complete cross hypersensitivity, complete hypersensitivity between different cephalosporins. Then there is cross hypersensitivity with other beta lactam antibiotics, penicillins, and your carbapenems, but no cross hypersensitivity with your yes, you're right, astrinam. Then they can cause pain at intramuscular injection sites, and they can lead to phlebitis, which means inflammation of the blood vessels. Phlebitis after IV administration. Next, they can cause nephrotoxicity, and then their nephrotoxicity can be enhanced by the use of aminoglycosides. Why? Because aminoglycosides themselves are nephrotoxic and your cephalosporins can be nephrotoxic. So when we use them together, there are increased chances of nephrotoxicity. Now this is very important to remember that cefamendol, cefoperazone and cefotetan, cefamendol, cefoperazone and cefotetan may cause hypoprothrombemia. Let me clear this. Cefamendol, cefoperazone and cefotetan can cause hypoprothrombemia. And one very important adverse effect which will be asked time and again is disulfiram-like reaction with ethanol. Now what is this disulfiram-like reaction with ethanol? Whenever we talk about metabolism of ethanol, ethanol is metabolized to acetaldehyde and then to acetic acid. There we have an enzyme which is alcohol dehydrogenase. There we have an enzyme which is aldehyde dehydrogenase. When we talk about a drug which is disulfiram, disulfiram is one of the drug which blocks degradation or metabolism of ethanol by blocking this aldehyde dehydrogenase enzyme. When we block aldehyde dehydrogenase enzyme, this ethanol will be converted to acetaldehyde, but this acetaldehyde will not be able to convert into acetic acid. Accumulation of this acetaldehyde in the body will lead to flushing, hypotension and severe headache. So a patient was having ethanol for pleasure. But when we have given disulfiram to the patient, that pleasure of the patient by ethanol will be converted to a punishment. The patient will have flushing, the patient will have hypotension, the patient will have headache, the patient will have nausea and vomiting. So the patient will try to abandon this ethanol. They have seen that some of the drugs have characteristics similar to disulfiram, which means when we use those drugs, if the patient in the presence of those drugs will use ethanol, the patient will have headache, the patient will have flushing, the patient will have hypotension, features similar to the disulfiram. So among those drugs, these three drugs, cefamendol, cefoperazone and cefotetan, these are the drugs which show disulfiram-like reaction. Which means if the patient is having any of these drugs and the patient ingests ethanol, the ethanol will not be converted into acetic acid. There will be accumulation of this acetaldehyde in the patient, and this will lead to headache, flushing and hypotension in those patients, and this will be termed as disulfiram-like reaction with ethanol. So today we have talked about cephalosporins, which are beta-lactam antibiotics. They are derivatives of 7-amino-cephalosporinic acid. These drugs are either given by oral route or parenteral route. They can be classified as first, second, third and fourth generation. First, second and third generation can be either given through oral route or parenteral route, whereas fourth generation can only be given through your parenteral route. First generation cephalosporins and second generation cephalosporins cannot cross your blood-brain barrier even when the meninges are inflamed, whereas your third generation cephalosporins can cross your blood-brain barrier. Your fourth generation cephalosporins can also cross your blood-brain barrier. When we talk about first generation cephalosporins, they are effective against gram-positive cocci. When we talk about second generation cephalosporins, they are effective against gram-negative bacilli. And your third generation cephalosporins are effective against gram-positive cocci, gram-negative cocci, and gram-negative bacilli and anaerobes bacteroids. Whereas fourth generation cephalosporins have same or similar antibacterial spectrum as that of third generation cephalosporins, but they are more resistant to your beta-lactamase enzymes. Here we have talked about one of the drug of choice, which is drug of choice for the treatment of gonorrhea. Please do remember the drug of choice for the treatment of gonorrhea is either oral cefixime or intramuscular ceftriaxone. In case the patient is hypersensitive to beta-lactam antibiotics, then we give either tetracycline or ciprofloxacin or spectinomycin or ofloxacin to the patient. Clear? So by now we have talked about 5 drug of choices. Number 1, drug of choice for the treatment of syphilis. Yes, come on please. You are absolutely right. This is benzathine penicillin G. Number 2, drug of choice for the treatment of infections caused by Listeria monocytogenes. Come on please. Yes, you're right. This is ampicillin. Number 3, drug of choice for the treatment of infection by Corynebacterium diphtheria. Come on. Yes, you're right. This is erythromycin. Number 4, drug of choice for the treatment of pseudomembranous colitis. Yes, you're right. The drug of choice for the treatment of pseudomembranous colitis is metronidazole. Number 5, today we have talked about drug of choice for the treatment of gonorrhea. Please. Yes, this is oral cefixime or intramuscular ceftriaxone. So with this, we come to the end of today's lecture, which was about cephalosporins, and in the upcoming lecture we'll be talking about carbapenems. Hope you enjoy the lecture and give your feedback in the comment section. Thank you very much.